Dr. Slepian, and we'll finish the session with one last talk on COVID, which is ECMO utilization in COVID by Dr. Zwischenberger.
So after a drive-by shooting by Marvin and a talk with an R value of 0.2 by Steve, I'm going to try to make sense out of all this. So I've got lots of conflicts. I consider myself neutral. So the bottom line is, through the ELSO database, right early on, we were hammered with data from Europe and the East that ECMO for COVID was worthless and the risk-benefit ratio wasn't acceptable and we were going to contaminate everybody in the hospital. So we were scared to death. But many of us tried to address this early on, and the first actual peer-reviewed paper showed a 55% survival using ECMO for COVID. Well, as I stand here now, there's been over 12,000 cases in the registry with the 53% out-the-door survival as of just a few days ago. So we're not stupid. We've done this before. We've seen viruses before and treated them with ARDS, and it was called H1N1. We did this over 10 years ago, and this was probably the best data was out of the United Kingdom, where we saw a 76% survival with ECMO and 50% with conventional care. Based on this, ELSO got together early on, generally about April, I was part of that, and we published in the ASIO Journal in May. Now we had an inside track because Marvin was the president. We had the editor, Mark Slaughter, so we could just put it out there. At any rate, we said the focus should be on younger patients or healthcare professionals, that was a little self-serving, with limited comorbidities might meet current ECMO ARDS criteria. Okay, but we were really worried. We were really worried about resource availability, personnel, expertise, equipment, whether there was enough beds. My hospital tried to shut the ECMO program down for lack of nurses, and of course, we fought like hell about that. But we also had to consider age, comorbidities. They've been on a ventilator more than 7 days, multi-organ failure. And most of us said, look, we're worried about the airways spewing these horrible viruses we don't know how to contain or what they're going to do. Let's just do groin cannulation with VV. So that's what we did. And we made those recommendations. And now I can tell you with confidence, after 2 years and these over 12,000 patients in the registry, we've gone back to the old days. We recommend ECMO for COVID with severe cardiorespiratory failure who meet traditional criteria when appropriate resources are available. So a lot of this discussion you've heard is on specific patients with specific problems and trying to come up with specific answers for them. But the big picture, we're back to where we were. You get into severe respiratory failure, it doesn't respond to conventional management, you go to ECMO. Just show this algorithm to show that ELSO has published guidelines for use of ECMO and ARDS in general, and that's what we're alluding to. Now, lots of papers have been out there where one particular study comes up with more salated, super detailed indications, contraindications. Our hospital tried to do that. They got put together an expert panel while I sat back and chuckled on the panel at the back of the room because they all wanted to come up with specific criteria. Well, we've been working on that for 30 years, right? So we're not going to come up with specific criteria, but if you want to publish them, it looks like that. Now, to review, there's basically 4 approaches. You can do groin access VV, but you can get recirculation. It's tough to walk around with two cannulas in your groin, one on the right, one on the left, and you get recirculation, but you can do it. I was talking to several nurses here today, and they've learned how to ambulate patients with venous cannulation, basically because it's a low-pressure system. You can do VV double lumen. It's actually very, very efficacious for ambulation, but you need image guidance to place it properly, either the Protect Duo, the Protect Duo, of course, and the Crescent and the Avalon all require image guidance. VA ECMO's been around forever, but it causes increased afterload, and you have to be able to handle a distal limb perfusion. And finally, the Protect Duo that you've heard the first 2 speakers talk about has come out, and many people have gained enthusiasm, but you have to be careful how you apply it. It's more expensive, putting it in is more difficult, and you know, if you highly select the patients and highly select them in the right place, and you pick the patients as to which ones to count, you can show it works. Now, in terms of a literature review, I looked at every paper that's been published on COVID just for fun, and there's no difference in the overall outcomes compared to ARDS. In fact, see that aggregate number of 53.6%? Remember that number back when you look at the entire registry was 53%. So when do you start ECMO treatment? Well, you heard a debate about that from our panel. They hit the nail on the head. When do you start? Well, I'll give you a little clue. The earlier the better, but don't do it too early. That's the answer. Why? Because we've studied it. If they've shown that every day of additional mechanical ventilation, once you go into ARDS, decreases your chance of survival on ECMO. And if you do ECMO on a non-ventilated awake patient, you get better outcomes. But you also steal those patients that would have done okay on the ventilator, right? So, bottom line, the earlier you start ECMO, the better off you are, but don't go too early. Finally, what about complications? Everybody loves to talk about ECMO complications because you can come up with a slew of them. Well, according to the registry, if you compare that to the regular ARDS ECMO patients, there's no difference. There's no difference. They're still horrible, but there's no difference. So, what are the current recommendations to date by all the smart people, right? If you look at per up to date, they say do ECMO for respiratory failure, refractory, and other therapies. Okay, got that. Prone positioning may work, we got that. Tracheostomy is often needed. Yeah, we understand that. ECMO flow is needed for full gas exchange. Okay. And you may need a beta blocker if your heart's hyperdynamic. Nothing new there. How about the NIH? Those are smart guys. Well, there's no conclusive evidence regarding refractory hypoxemia. Okay. It's dependent on variable factors. We heard that from Marvin as he showed 35 slides. Finally, we need a controlled trial. Well, nobody's going to do a controlled trial on these patients as they pass through ventilator management and ECMO as a desperate rescue technique. Good luck with that. So finally, the ELSO recommendations came back to exactly what I told you. We should not differ in our thinking from COVID ARDS, other ARDS causes, which is exactly what we learned in H1N1. The younger and healthier you are, the better you do. And it's better if you're refractory to other managements, you could justify the cost and expense and effort. Now, I joined a group that does long-term outcomes for COVID patients on ECMO. It's called Oracle, and it involves 6 major institutions. What we found was the long-term sequelae of COVID on ECMO versus ventilator management of those that survived the ICU is similar. Shouldn't surprise you. It's a virus. It affects all these different organs you heard about, and it does it without discrimination. There's significant long-term deficits that follow a critical illness for all COVID patients. True. ECMO is not associated with worse long-term outcomes. So if you survive the ECMO, you've got the same pathway as if you survive ventilator management. And finally, a few immunocompromised patients slipped in, so I thought I'd tell you about them. If you've got cancer, that's a bad idea. If you got metastatic cancer and you're immunocompromised, no. But if you have a lung transplant, you're doing well, or a heart transplant, your outcome is pretty good. So that's it. That's the overview. If you know ARDS, if you know ECMO, you know COVID ECMO. Now, you can morcellate certain circumstances, but overall, keep your head on and don't go crazy. Just do the right thing.
Any questions in the audience?
It's open season up here, you can tell. Look at them. They can't wait.
You know, when we were meeting with the consortium, we decided along the way that our traditional VV ECMO criteria, age 75, blah, 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 we really had to lower that. And what we shifted to throughout the pandemic was those patients who met criteria for lung transplant. Because the last thing we wanted was somebody on VV ECMO without an exit plan. So we really did differ from our traditional ARDS criteria for VV.
But you did that early on, right?
Yeah.
Yes.
Yeah, of course. Everybody was real conservative at first. First of all, we didn't have the personnel. Secondly, we didn't have the beds. Thirdly, we didn't have the expertise to know it was going to really work. And fourthly, we had our administrators hammering on us not to do it at all, right?
Right.
That makes sense.
Jay, I think one follow-up from Joyce's point is that first article, which thank God for its publication, but also for the leadership that was shown by La PTA. You know, Alan Combs and La PTA really, that was the East that really told us, hey, don't believe what's coming out of another Eastern country. It's not true. You can actually do ECMO for patients and do well. That was Alan Combs and Pascal Leprince. Thank God for them because we were able to actually institute. And that was the genesis of doing that that call on Friday was, hey, let's just really learn from people that are actually able to tell us with numbers. But the question is, so do you think they are similar survival because of what she just said? I think the patient selection we had early on was a little stringent, but I'm not an expert in this. I would just defer to people that did more of this, and I'm curious what your thoughts are on that. If you think we really would have equivalent
So you're
survival.
absolutely right. What we saw was a two-year evolution of the selection process. And now we've glummed it together and done a comparison. Obviously, that's not perfect data. The previous two speakers were clearly aware of that. And when you look at how it's evolved, we still have to base our utilization on resources.
ARDS data, yeah.
We're in little old Lexington, Kentucky, we were doing up to 13 ECMOs at a time. We were overwhelmed. I mean, we had the cardiac surgeons calling us up and saying, you're interfering with our elective cases. We don't have elective cases, but we call them urgent, and we're doing our elective cases urgently, and you're interfering. So you were quite right. Early on, I was on a committee where they were trying to shut down our unit for ECMO and say it's too intense, it's too labor intensive, we shouldn't do it. So thanks to Marvin and the SIO group and the ELSO group, we quick published those guidelines.
Yes.
So that I could go to the committee and go, look, the expert opinion is we should be doing this, right?
Ali.
Oh, sorry.
Thank you. I think it's regarding the outcomes and complications. I can talk from our experience. We achieved the same outcome for COVID, ARDS, ECMO patients similar to non-COVID patients, but we were more selective in COVID-19 patients when we selected patients going to ECMO. They are younger, they are having lower BMI because of the surge, because of the number of patients we did get, and we changed our inclusion criteria. That's number one. Number two, the profile of the complication might be what we have been able to, or we watched, that we have more bleeding, but that might be related to the extended period of time the patient required on VV ECMO compared to a non-COVID patient. We watched that the lung recovery, lung healing, it took longer time than non-COVID ARDS patients. That's our experience, and might be the complication was associated with that time, not because of the primary disease, but because of the longer time those patients were on ECMO than the other, which was associated with von Willebrand syndrome and more bleeding. We watched later on in their time
So Ali,
on ECMO than others.
what you're saying is maybe if we adjusted for time on
Time on
MCS,
on
maybe our
yes.
outcomes would look better. That's interesting.
Yeah.
That's interesting.
So you heard it here first. If you really want to screw up a good database, just change your selection criteria on the fly.
So thank you very much for this talk again. So one of my questions is that with the advent of these, us getting really better over time in this COVID era of non-rebreather, vapotherm, using nitric oxide or inhaled Flolan to deal with the hypoxic respiratory failure, and us prolonging the ventilatory support for 2, 3, 4, 5, 6 weeks sometimes. Wow. Do you take that consideration of time on when you select or recommend anyone for MCS? Because the longer you are from your index admission, the chances of you developing severe ARDS and fibrosis goes higher and higher, and the chances of your recovery are lesser and lesser. So is there a 4 weeks, 3 weeks, 2 weeks, when should we do? We have this arbitrary timeline with the RESP score that anyone who has a less than 7 days on the ventilator would be a good or ideal candidate. What do we do with those patients who actually have dense ARDS on 3 modalities with vapotherm, non-rebreather, nitric oxide, Flolan, and despite that they're not improving?
So you hit the nail on the head of what many of us had to face. And that is, we were doing all these different treatments for the ARDS of COVID, and we would run into the idea that earlier is better, but we wouldn't have a bed available. Yeah. So by default, we were having patients that went longer and longer and longer on ventilator management, and then we were throwing them on ECMO, or we were placing them on ECMO later in the course than we wanted to. And we thought they didn't do as well. Well, that's what the literature showed. The longer you wait, the worse they do on ECMO. But when you look at the aggregate of the 12,000 patients versus ARDS, you can't show a difference.
Okay.
So earlier is better, what can I say?
Even though if they are not ventilated, they
Even
are
though what?
They are not ventilated and are on non-invasive therapies, for example, vapotherm, they are not on a ventilator, which we know can cause volume injury, atelectasis.
Right. At our
ventilator-associated
institution, we
pneumonia.
never put somebody on ECMO unless they'd gone through the ventilator first.
Okay, that's good.
Yes, sir.
Jay, fantastic talk.
That's the last
Question for you, as you described a lot of the pain that those of us who were trying to get ECMO up and running in the United States at the beginning of the pandemic went through, a thought crossed my head, well, how do we prevent this pain in the future? What have we learned through this process of saying, maybe we got some disinformation, we had as a community significant faith that this is probably a good therapy. So what have we learned? How do we prevent going through this same experience again with the next virus that comes out? Why didn't we remember the lessons of H1N1? Why did we have to recreate the wheel?
Well, that's an extremely important point for the people attending here. I call it administrative panic because I was part of it. Marvin was part of it. Many of us in leadership positions had to deal with administrative panic when the pandemic hit. I mean, we ended up building a whole field army hospital for millions and millions of dollars that nobody ever set foot in. And then we spent another couple million taking it apart. So the point is, if we'd taken some of those resources and put them towards ramping up for the critical care that we knew we were going to have to do, I mean, the rubber hits the road in the ICU, right? If patients were just in the hospital and then they got to go home, there was no challenge. It was all based on the ICU. So I think those of us that are specialists in critical care have to educate the administrators that this can't be based on panic and thinking that they're going to build an Army field hospital that doesn't even have an intensive care unit. That was a waste of time, money, effort, administrative meetings out the wazoo, and yet we didn't get the resources in the ICU initially. None of us did.
Manny, maybe we'll have ambulatory go-home ECMO by the next time this pandemic.
I hope so.
Where's Bart Griffith when you need him? Oh, he's doing pig hearts. That's right.
Thanks. So we'll bring the session to a close.